material at both patients and caregivers. And the fact is that these are two different jobs, aren't they? Patient and caregiver, and they're both very challenging. From the patient's point of view, the fact is that just when you need the most resources in your life, you have the least. And from the caregiver point of view, you're constantly asking the question, how much support is too little and too much? And that's particularly difficult in Parkinson's disease, a disorder where sometimes symptoms can change from one day to the next, even 1 hour to the next. And so that really is, poses a tremendous challenge for caregiving. And of course, a caregiver is not doing a good job unless they're making time for their own self-care. So what are some of the challenges of navigating healthcare for both patients and caregivers, or care partners? They include things, as you all know, like coordinating your medical visits, your tests, your different drugs, your treatments, like managing all your different doctors, nurses, and therapists, like getting the most from each office visit. We'll be talking about this more. And then on top of it, the need to track the costs, the insurance, the co-pays, the authorizations. I mean, if it's sounding like a full-time job, it's because it oftentimes feels that way. So how do you achieve the best outcomes in such a challenging healthcare environment? It's very important to understand the skills of being an effective patient and care partner. And that's because similar health problems can lead to different health outcomes. In other words, if we found two people in this room, two people with Parkinson's, who had very similar stages of disease and kind of a similar support system and so forth, a lot of similarities, where they end up 5 years and 10 years from now is not necessarily going to be identical, because people who navigate the healthcare system better, who understand how to utilize, to be proactive and to be effective in their advocacy for themselves, will do better. So the best outcomes depend on, as I say, being an effective manager. And this includes learning effective management skills, learning to manage your medical condition, learning to also manage the health system, and all the time also develop a sense of confidence and control. Because when people first receive a serious diagnosis of any type, there's a period of time where understandably you're thrown off. It's not what you expected, you feel like you don't know really how your life is going to go, how to care for yourself from this point on. And for some people, quite frankly, as a Parkinson's physician, sometimes we see people who never quite get back on their feet. And, most people do go through a period of adjustment and then are able to develop more sense of control of their life. But people still vary a lot. So how did our health system get this way? Why is it so complicated? And every single person here, whether you have Parkinson's or not, we all are patients sometimes, and we all find out that the healthcare system is really, pretty much a mess. So, part of it is that many good things in healthcare turn out to be really a double-edged sword. You might not realize it at the start. So, for example, medical specialization and subspecialization. Like if you go back like 50 years and more, there weren't that many subspecialists. And now, the good news is, and the bad news, but the good news is that we have loads of medical specialization and subspecialization. What I mean by that is a neurologist is a specialist. A movement disorder specialist is a subspecialist. So that's great because we have greater experience and expertise out there. However, that means that not a single person doesn't have numerous doctors that are treating them. And our system is not very well set up still for that. That is still a problem. At the University of Maryland, we have a lot of ease about communicating with other doctors in the University of Maryland system. But then when people come in and they've seen it was just fine, seen other doctors, we have to make all special efforts to be in communication. So another thing that was a double-edged sword is advanced technology. Because we have more and more tests, more and more drugs, more and more sophisticated treatments. But that has resulted, of course, in more and more cost. And every single treatment, every single drug, every intervention has risks and benefits. And we have more and more treatments. So there's more and more to discuss about risks and benefits and more difficult decisions to make. So the advances in medical care include things like, this is great news, earlier diagnosis. We have more and more tests, more and more drugs to treat. We have longer life expectancy over the years. However, this has led to spiraling health costs. And in the graph, it shows that it shows 65 years of healthcare expenditures. And believe it or not, and I checked these figures, they are correct. In 1960, healthcare in the United States cost $1 billion. And now it costs $5 trillion. $5 trillion is approximately, it's over $15,000 per person every year. So, you know, our expectation in the United States is that everybody will have. How are you going to judge that? Because with so many medications, there isn't a person in this room, no matter how much knowledge and expertise you have in healthcare, there isn't a person in this room who can always unravel what is a symptom or a side effect of a treatment, or of what symptoms you're having, whether this is associated with Parkinson's disease or any other number of disorders that you also have, or maybe that haven't been diagnosed. And then you have to unravel which doctor to see for the problem. If you make that choice poorly, obviously your care, the proper care, will be delayed. So these are all common questions that people confront. And every one of these questions and decisions are pivotal in terms of how your care goes. As a physician, how many times do we see people who, for example, go to the emergency department for a symptom and then may even get admitted and get all sorts of tests and treatments, and maybe the treatments aren't that great for their Parkinson's, and maybe they never even had to go to the emergency department. So what are the challenges, on the other hand, of being a care partner? So, one of the most important things to think about is that the care partner's role is actually very poorly defined in healthcare. I went to medical school long ago, but I don't think it's changed. Medical students are not taught how to take care of caregivers. It's not part of the education to really know how to incorporate and integrate care partners in a dynamic relationship that will be therapeutic. So, I think most of us are basically learning on the fly about how to do this, and we want to incorporate and integrate the family members in the room in an effective way. But it isn't something that necessarily we're taught. As a matter of fact, for many years, and I think to some degree it's still true, insurance quite literally said that, you would be reimbursed by their insurance for face-to-face time with the patient, not with the care partner. You were literally being told, you're not caring for the care partner, caring for the patient, that's what we're reimbursing for. But I would say that that's wrong, because if you want to get a good outcome, the family has to be part of the discussion. A very important part of this is that many studies now show that the physical and emotional health of the caregiver is also at risk. And this is really a failing of our system, that we don't have automatic ways to make sure our caregivers are being properly taken care of as well. And these include increased risks of chronic illness, quite literally, like hypertension or diabetes. This is in studies where you are looking at people who are involved in caregiving, or more obviously back and shoulder injuries when you're caring for people who are disabled, sleep disruption, mental health problems like depression, anxiety, social isolation, and burnout. All of these things are very at increased risk, more prevalent in our care partners. There's an interesting difference between the perspective of care partners and patients. And what I mean by that is if we ask patients how they're doing in various ways, and we separately ask their care partner how the patient is doing, you get very different perspectives. And many, many studies, including our own studies at the University of Maryland, have shown that the caregivers tend to rate most domains worse than the patients. For example, in this graph you can see that the because the vertical axis is the score difference between the caregivers and the patients. And what it's showing you is that the caregivers rate the patient as having worse physical function than the patient says. The caregiver says the patient has more trouble with their daily activities than the patient says. This is also true of reports of pain, fatigue, depression, anxiety, cognitive function, quality of life, and the caregiver reports that the patient has more risk for their safety than the patient reports. So, this kind of like harkens back to the play we saw, because, you can see where patients and their care partners are coming from different perspectives on how things look. So how are you going to learn to use your doctor's visit wisely? I mean, the first, most obvious thing is to educate yourself about your medical condition, because the more you know, the more you can make educated decisions. But there is there is kind of a proviso to that, and that is that you don't want to be like your own Dr. Google and Googling everything all the time, because it could be just a preoccupation. And if you keep on looking at things, you're bound to find things that are upsetting and distressing. So you have to find like some sort of a happy medium, that you're learning enough that you can be a wise, proactive patient, but not so much that you're imagining you ever hear about medical student syndrome, where a medical student is imagining they have every disease that they're learning about. So by having more fund of knowledge, hopefully you're gaining in your self-management skills, and you then, most importantly, are increasing your self-efficacy, which is your control and your confidence. So for example, when to schedule an earlier office visit. Not every symptom requires an earlier office visit, but some symptoms do. If it's a complicated thing, it's not the kind of thing necessarily that a phone call or a portal message is going to be helpful for. And when to go to the emergency room, as I said before. So Dr. Google is a great thing, and it's an important resource if used wisely. But you want to learn enough, but not too much. And you always want to check what's the source, because there are a lot of things on the web that are just frankly wrong. And unfortunately, now there's a lot of things coming from our government that are frankly wrong too. Okay, so to use your doctor's visit wisely, Matthew Moore talked about lists, and I'm going to expand that to talk about how to prepare 3 different lists. One is a problem list, one is a medication list, and one is a question list. And you want to prepare those lists before you see your doctor, because a doctor's visit is a short period of time. And by preparing the list, this is going to allow you to think through and prioritize what are the real things you want to make sure you get to during this visit. All too often, without a list, people sit down and they talk about the first thing on the top of their head, which may be what happened yesterday or this morning, and then you're using up your time on something that's just not the priority. One of the best ways with Parkinson's disease to handle this is to keep a symptom diary. A symptom diary, I'll show you an example in a moment. You can keep a diary for just a few days, and you can then drill down into the timing of your symptoms and the time of your medicine doses. It's like such a treasure for you to describe or give your doctor, your Parkinson's doctor, a diary. And this is what happened the last couple of days. I can't understand it. And maybe your doctor can, unravel it. Or keep your diary for months. I think it's even better if you just generally keep a diary, because that's a way to gain perspective on patterns over time. One of the problems with having a chronic condition is that it's very hard to keep a perspective on what has gotten better and what has gotten worse. And sometimes, like you're constantly feeling like you have a new problem and then you're very focused on that. And sometimes we forget, well, I forgot. 6 months ago I had this whole other set of problems and those are gone. And when you see that, you look back and go, okay, by making adjustments, things actually improve. So no one can rely on memory alone. Not one of us can rely on memory alone. After all, especially when you're with a person with a condition, you're living with the symptoms, and they're very pressing when you're having them. Hard data is always better. People make fun of neurologists because actually we're very data-driven. That's true. So, what's an example of hard data? Let's say somebody is going to come in with Parkinson's and say they feel lightheaded when they're standing. And then I bet your doctor next says, when did that happen last? How often does it happen? And a lot of people are like, well, maybe this. But if you kept a diary and you wrote that down and you said it happens 2 times a day, and on top of that maybe you had monitored your blood pressure when you were feeling better, when you were feeling worse, because you had heard that feeling lightheaded standing could be a blood pressure problem, you've propelled your care forward by months, because your doctor is able to respond to it in a pinpoint way. Here's an example of a Parkinson's disease patient diary. It's really not my favorite, and I did Google this. And if you Google Parkinson's patient diaries and you look at the images, loads of them come up. So a better patient diary than this one shows time, your motor status, whether you're on or off, meaning on that your medicine's working well, off your medicine is not working well. Then it shows dyskinesia, those involuntary movements, non-motor symptoms, that's way too vague. There's loads of non-motor symptoms like blood pressure drops, lightheadedness is a non-motor symptom. But what would be a better diary would be especially a column that shows when you take your medication doses. And then on the diary, then you're putting what's happening after each medication dose. That is what is going to be really helpful to us. And you would change one of those columns to something that's specific to you. Like if your problem is freezing of gait, that your feet get stuck on the floor, you make one of your columns freezing of gait. Or let's say your main problem is tremor. One of your columns should be tremor. And this is when you're going to show when you're freezing or when your tremor is happening compared to your medication doses. So understand how your doctor's visit is organized. And what I mean by that is your doctor has been taught, and it makes sense, to organize an office visit by starting with your history, doing an exam, then telling you what the assessment is based on what they found, and then telling you what they are recommending about the plan and discussing it with you to make a shared decision about what to do next. One of the most important things also you can do is think about who else needs to know about this visit. And as I said before, to bring along lists of names, addresses, and phone numbers of your doctors who you want us to be in contact with. Because otherwise, it's a lot of work for us to figure out who this primary care physician is out in the community. So, really, there's a positive feedback loop that's going on, and this is really key. And that is, after your visit, the ball's in your court. And what I mean by that is that you've been told, this is the recommendations, this is the plan, and that's kind of a compact between you and your clinician. And now it's time for you to implement the plan and provide feedback that's accurate. And we're trusting in you to provide that so that we can keep on moving your health forward. Here are some examples of ineffective self-managers. Bob leaves the office without actually understanding the plan, and he returns 6 months later to the office on the wrong dose, and he never got his MRI. Here's another example. Susan tries a new dose of medication that was recommended. It doesn't make a difference, so she stops the medication. And she returns 6 months later with the very same problems. So what has happened here for both Bob and Susan? They completely wasted their previous visit. And all this time went by, 6 months or maybe even a year, where they have the same problems, and because they're not being proactive and good self-advocates and self-managers, we're not able to respond timely, in a timely way, and we don't make any progress. We see this all the time. So quality medical care involves trial and error. You know, we don't have a crystal ball. Some people do great with medicine A and some do great with medicine B. If you can't follow the recommendations when you go home, immediately contact us, and don't let months go by without providing important feedback. And in order to really contact your doctor, the only best way to do it is really the patient portal. Guess what happens to your phone calls? They're transcribed into the portal. And so it's just a delay. But we're all looking at the portal, and you'll get quick answers, hopefully that way. So it's most things, including Parkinson's, of course. And we're talking about physical activity, cognitive activity, and social activity. And I love this last bullet. Be a participant, not an observer. And it's so important in life today because so much of our life is looking at screens. Sometimes we could forget to be a participant. We're not just observers. You know, the old view about the brain, and it's not so old because this is the view when I became a neurologist, was that only muscles could be changed, not the brain. That's what we were taught. But the new view, the modern view, is that even adult brains are plastic. And that what I mean by that is that remodeling and rewiring the brains can be done based on our lifestyle. That is what the definition of neuroplasticity. And you can see right here 2 nerve cells, neurons, and show how when you go from low activity of that circuit to high activity, our brains are plastic. That means it wires up for what you keep on doing over and over and over. So when you practice something, like your exercise, or whatever it is that you want to move in that direction, your brain is actually rewiring itself so you can do better and better. So practice and repetition results in remodeling and rewiring the brain. That means that we all have an incredible tool in our own hands all the time. You can actually be the sculptor of your own brain. Thanks a lot.
And says I got 25 minutes, but I think so I'm going to talk about ways that we diagnose Parkinson's disease and some of the old ways and new ways. My slides have a lot of detail for people who like to read, but I'm basically just going to be talking about stuff, so don't get too wrapped up. You know, neurologists love details. They make fun of us. Data. I'm going to describe our latest understanding of why we get Parkinson's disease, and then finally I'll talk about some of the new treatments and some of the new studies that are out there that give us all even more hope for the future. So I'm going to start with talking about diagnosis. So people have been diagnosing Parkinson's disease the same way for millennia. So we've known about how to diagnose Parkinson's based on a person, how they look, how they act. So even 1,500 years before the Common Era, before the birth of Christ, people had described Parkinson's disease. In an old Sanskrit text, there's talk of people who have tremor, who maybe have drooling, have a stare, they don't blink their eyes as much, and they seem, at least to them, like they were a little bit depressed. And these people are thought to have had Parkinson's disease. They also knew back then that there was a plant called cowhage. It's also called, and what's also interesting is when we see tremor and we want to make a diagnosis, we look for signs on one side more than the other. This asymmetry is very common. There's also a bunch of non-motor symptoms, and I've listed a bunch of them here. But some of the things that help me in diagnosing, I ask people, how's your sense of smell? Has anyone ever told you you act out your dreams while you're sleeping? Were you recently diagnosed with anxiety or depression and you never had that issue before in your life? These are things that offer some clues when we're trying to make a diagnosis. Because for most people, if you look at these features, it seems pretty obvious. When someone walks in, how to diagnose them. But it's not always true. What happens is sometimes you get, there's a little bit of tremor. In 1/3 of patients, there's never any tremor. So it's a little bit tougher to diagnose with a new person coming into the office. But these are the ways that do. One of the new things that's getting a little bit more attention from a recent article is the incidence of pain. So a lot of times we think of movement disorders, we don't think so much about pain. I know for my patients, people have shoulder injuries or back pain or knee pain or hip pain, and they want to go for surgery. Sometimes they'll say, let's try a little bit more medicine and see if the pain gets better. And that, the burden of pain in Parkinson's is becoming a little bit more well understood. So the other final thing when we diagnose Parkinson's is we give people Parkinson's medicine. It's kind of circular reasoning. If you do well in Parkinson's medicine, you probably have Parkinson's. If you don't, then we worry about other things, other mimickers. And I've listed some of them here. They're fairly uncommon, but things like Lewy body disease, cortical basal syndrome, PSP. So these are the types of diseases that sometimes fool doctors and patients when someone doesn't actually have Parkinson's. So we look at a little bit of the timeline too, and we talk about in the field of treating Parkinson's, that every once in a while we should reevaluate the diagnosis, make sure we got it right, make sure we didn't screw it up. And so this is a timeline. If you look at the bottom, it's years, but it doesn't say how many years, because everyone progresses a little differently. So some people, before they're even diagnosed, they may have problems with constipation, they may lose their sense of smell, act out their dreams. So these are the things that kind of happen before symptoms start, and then over time, motor and non-motor symptoms kind of accumulate, and the patient and the caregiver and the physician, our job is to try to treat these things and make them less of a problem. So that's how we basically do the diagnosis. It's a clinical diagnosis because there is no test that can definitively say you have Parkinson's disease. It takes someone who knows what to look for, has some experience, or knows how to look it up online to make the diagnosis. So what's going on? Why do people get Parkinson's? So I'm just going to introduce a little bit here. There's an area of the brain called the substantia nigra that has cells in it that are darkly colored. Substantia nigra just means black substance. These cells make dopamine, and that dopamine is then projected up to a different area of the brain. When these cells start to die off or don't function the way they're supposed to, there's a dopamine deficiency, and that leads to Parkinson's disease. If you look closely in the middle panel here, the spots that have all the dark dots in it, that's a normal area, a non-Parkinson's area, a non-Parkinson's disease patient area of the brain that has those little dark spots. Those are dopamine neurons. Just below that, you can see there's a similar slide without so much dark stuff in it. That's Parkinson's. Those cells that make dopamine have been lost. And what happens is you get less dopamine to those other areas. And why I'm talking about this here in a second, the other thing that I just want to mention too, because I'll talk a bit about this, we found out in the late 1990s that if you look at the cells that remain in a person who has Parkinson's disease, they have an abnormal protein in them called synuclein, or a form of synuclein that's abnormal. And this has become a marker of the disease as well, and that'll be important in a little bit. So one of the ways, and it's not that new, it became available in 2011, is something called a DAT scan. And what a DAT scan does is it can help us diagnose Parkinson's disease. So some people in this room may have had one of these. These are tests that are often used to help us confirm what the diagnosis is. Is it truly Parkinson's? Is it another type of tremor disease? Is it something that's caused by medication exposure? And so what you can see on that, the normal scan up there is something that looks like a comet. And that's where the dopamine is. So remember I showed you that slide and those little tubes that went up and dripped dopamine into this area. So that's a scan, which looks like a comet. Next to it, it looks more like period or dots. That's an abnormal scan. And people who have Parkinson's disease, that's what their scan will look like. It's not perfect. Sometimes it's wrong. Sometimes it's abnormal and things that aren't Parkinson's disease. So it helps us make the diagnosis, but it doesn't necessarily nail it, right? One of the other ways that we have a need to help us diagnose it is doing a biopsy. Most commonly now it's a skin biopsy to look for evidence of that abnormal protein I mentioned a moment ago, abnormal alpha-synuclein. And what some of the people believe is that Parkinson's not only is labeled by this abnormal protein, but in some ways is actually caused by it. And again, this is a bit controversial, but people believe that this abnormal protein may form in the GI tract, some say in the appendix. We've seen it in colonoscopy samples. We see it in the kidneys. We see it in the nose and ears. So there's areas that have this abnormal protein, and some people believe maybe these are where the seeds of this disease start, and then it travels to the brain and causes Parkinson's disease. But how we've managed to make use of this is by doing skin biopsies. So this is a slide, that little kind of reddish-orange fiber is a nerve fiber from a skin biopsy that has abnormal alpha-synuclein. And for those of you who may have had this done, we do three little punches of skin, and we send it off to a lab, and then they look at it and can make a diagnosis of Parkinson's. This test also is not perfect, because this test will also be positive in other disorders besides Parkinson's, in Lewy body disease, and in another disorder called multiple system atrophy. There's been a very recent article a few days ago maybe, that says we can actually determine what type of Parkinson's or Parkinsonism a person has based on these biopsies, but the jury's still out on that a little bit. So this is a powerful tool, and it's getting better and better over time to help us make the diagnosis of Parkinson's. So these things are out there to help the clinical judgment, the clinical examination, to help us make these diagnoses. One of the other things, I kind of threw this in here, not many people are getting diagnosed through spinal taps. But what we have found, again, kind of talking about newer things, is that when we take spinal fluid out of a person with Parkinson's and we analyze it and we look for this alpha-synuclein protein, we find it. And we can also tell by the amount of it, it may tell us a little bit something about why someone gets Parkinson's, whether their genetics plays a role. And this is something, again, more for the future. We don't use this typically to make diagnoses, but it's a bit of a research tool that may become important soon. All right, so that's kind of talking about diagnosis, and sort of to summarize that, we still make the diagnosis clinically. As physicians, we look at people, we look for their signs and their symptoms, what we see on exam, we listen to their story, we ask a ton of questions, and then we see how they respond to medication. And that's how we make the diagnosis. And every couple of years, I like to kind of look at patients and say, yeah, okay, this is the right diagnosis. There isn't something else going on. Right? And we have some tools. Physicians have tools to help us make the diagnosis when we're not sure. One of them is a brain scan, another one is a skin biopsy. So I'm going to move on to my next little topic here, which is what causes Parkinson's. And for many years, I think most people have subscribed to this notion that for most illnesses, there's a genetic predisposition, and there's stuff that we're exposed to in the environment. With Parkinson's, there's another factor. People tend to get Parkinson's around the age of 60, so time or age plays a role. That's kind of shown up here. And then there's also perhaps even a role for chance in how people may or may not develop Parkinson's. So I'm going to touch on these all a little bit briefly, and some of the newest findings, or in some ways the newest trends. So I originally got involved in Parkinson's research back when we thought it was an environmental disease. You were exposed to things, there wasn't that much in the way of family history, but now we know quite differently. We know that there is a whole variety of different genetic risk factors, and they kind of fall on a spectrum. So, but it kind of shows here there are certain genes, things that we inherit from our parents, that put us at very high risk for getting Parkinson's. There's also some genes that are very common that put us kind of at low risk, but they still, as they accumulate, can put us at risk. So we know that their genes are playing a role. The two ones that are most common these days, one is called LRRK2, and one is called glucocerebrosidase. It's also goes by just GBA. These are the most common and probably the most influential genes because they're so common in the population, and they also increase risk of Parkinson's. So having these particular genes puts people at risk. It doesn't always guarantee that you're going to get Parkinson's, but it puts you at higher risk. And so the way we kind of look to balance the genetic contribution is also with environmental exposures. And we see this in animal models of Parkinson's too. So you can make a mouse that's predisposed to get Parkinson's, and if that mouse is exposed to certain chemicals or certain environmental factors, it goes on to develop disease, where sometimes if they're protected from those factors, they don't. So it's the interplay of both. And this is nicely shown, this old slide from, it's not that old, 9 years ago. So there's certain things in the environment that appear to increase the risk of Parkinson's. So pesticide exposures, head trauma, a variety of different infections potentially could increase risk. I recently started working at the VA, so I'm around a lot of veterans. Veterans who Marines who were stationed at Camp Lejeune seem to be at higher risk for a variety of diseases, including Parkinson's. And certainly those who served in Vietnam who were exposed to Agent Orange are at high risk for Parkinson's. So we know that there's some environmental component. We know that it interplays along with genetics. And there's also some things that appear to be protective. It seems like people who drink caffeine, and this is just reiterated in a recent study again, coffee drinkers seem to somehow be a little bit protected from Parkinson's for reasons that aren't clear. Doesn't mean you go out and drink a lot of coffee. We don't understand it. But there seems to be an association, not a causation. Same thing with cigarette smoking. We were just talking about that a second ago at my table here. So I used to think people, smoking protected against a lot of things because you're dead from something else already, right? So you don't get old enough to get Parkinson's. That turns out not to be true. And why people who smoke tend to either get Parkinson's later or not at all, compared to people who don't smoke, is not entirely clear. We know that exercise protects people who are more active, tend to get Parkinson's less frequently, and their Parkinson's is certainly better managed with exercise. That being said, I have several patients in my practice who were marathon runners when they got Parkinson's. So maybe it helps an average person, but it doesn't help everybody. So none of these things are absolute. Certain medications, possibly anti-inflammatory medicines, beta blockers or another one, perhaps can protect us against Parkinson's, but the jury's still out on this. So why I kind of bring all this up, because this is a bit of an old argument and an old slide, is that there's a trend in the past few years where there's a group of doctors who are quite well known in the Parkinson's field. I met them all personally. They put out a couple of books, and one became a New York Times bestseller that talk about how to cure or manage or prevent Parkinson's disease. And one of the main features of their argument is a little less on the genetics and a little bit more on exposures. So in the absolute, we can, I take this with a little, not a grain of salt, I take a little bit of skepticism, because Parkinson's was around before many of the risk factors that people talk about. So thousands of years ago, there was no Agent Orange, there was no Camp Lejeune, but there were, perhaps certain things that put people at risk. So we do know in some really recent studies, I looked at the most recent ones, there are people who, it was found that when you're exposed to more pollution and have a disease related to Parkinson's called Lewy body disease, there was more hospitalizations with certain types of pollution. There were exposure to certain types of pollution, air pollution. There's some concern about pesticides. This was a French study. If you look at the clouds floating over France, apparently they're full of pesticides. I'm sure our clouds are too. So the same things that put people at risk, and you try to prevent them, may be raining down on us. So, a little bit more pro-environmental maybe needs to be pushed a little bit harder. And that's what these physicians who wrote these books are actually talking about. There's some evidence that a more processed food diet also can put you at higher risk for Parkinson's. So the whole thing, in these books, there's a 25-point, one book, the Ending Parkinson's, or the plan. Parkinson's plan has 25 pointers on how to prevent or improve Parkinson's. I think it is pushing an agenda. Oprah got on board, she identified 7 of these 25 that she thought was good. This Oprah Winfrey. If you heard her, she's a Baltimore, she was a newscaster in Baltimore, did well eventually. So the Oprah's points were eat more fruits and vegetables, yeah. Don't get diabetes, yeah, all right, makes sense. Air purifier, I have one because I live in downtown Baltimore and there's too much traffic noise, so my air purifier makes a lot of noise. So I don't have to hear the sirens and stuff. Don't water filter, wash your fruits and vegetables, wear helmets if you're doing something where you could bump your head, and get good sleep. So those points, I mean, no offense to Oprah, but yeah, I think these are all points we could all probably live by. Kind of common sense when people say, what's the best diet for Parkinson's? Well, probably the same diet that's best for everyone. We talk about the Mediterranean diet, reduced processed foods, and what's good for everyone also translates to Parkinson's. So I bring that up because it's just kind of a hot topic these days. So I kind of went into, how do we diagnose it, a little bit on why we get it. So we're looking at more and more environmental factors. We're always looking at new genes. So all those things are happening. So what I'm going to talk about next is just the treatment. And this is kind of the thing that's very exciting. And I'm very also heartened to see that most of the stuff I'm going to talk about that's brand new is right out there with people talking about it. So all the newest things, I kind of got a couple of heads up from some of the reps out there on some of the finer points of these new therapies. So what are the therapies in Parkinson's? So the main one we talk about is replacing that dopamine that I said was not quite, people's brains aren't making enough dopamine. So what do? We find a way to replace it. And one of the greatest discoveries was this notion that you can give a precursor, levodopa, because dopamine, you can't give dopamine because it doesn't get into the brain, it doesn't work. You give levodopa, it turns into dopamine in the brain, and then therefore you get more dopamine in the brain, your Parkinson's symptoms get better. So the carbidopa levodopa, old brand name was Savitt. It was originally approved in 72 and was available probably around 1974. There was an extended release version of that came around 1991 or so. It's a little bit better maybe than the original stuff for lasting longer, but it's not quite as reliable. And there's a whole variety of different doses that physicians use to try to fine-tune how much you get. It is the most effective medication. And then, many years after, it was actually proven to be effective by a study that was done, it was 2004. So there was finally a study that showed if you take placebo, you give someone a sugar pill, you give someone 150 milligrams of levodopa a day, higher and higher doses, it actually works better and better. So something that we all knew, finally in 2004 was proved with data. And as many of you probably know, levodopa is not perfect. It does great, especially for the first few years. Sometimes we call it the honeymoon period. The first 2 to 5 years when levodopa is great, and it's like you don't hopefully have much going on. You feel like you just take those 2 big pills and get on with your life. Over time, though, people run into fluctuations where the medicine may wear off, kick in, take longer to kick in, and then there can be side effects. So what ends up happening is people want to take more and more medicine to keep from wearing off, but then they start getting side effects. And I kind of show that on that little graph there. So what happens, as the disease progresses, you may need more medicine. As you take more medicine, you get more side effects. And that's where we get into a little bit of trouble. So one of the first things that we do is, if you're having side effects, we try to maybe lower the dose, but maybe give it more often so it doesn't have a chance to wear off. So many people go from taking levodopa 3 times a day to 4 to 6. Once you get around 6, it's hard to remember, I think, to do it that often, and it's not the most convenient thing. So we'll talk a little bit about some of those therapies. You can also make each dose last longer, and that's where a lot of the research has been, how to make levodopa last longer. I'll talk about some of the newer therapies for that. So one of the things I talked a little bit about, I don't have anyone who takes this drug. I don't know if anyone does. This is a form of levodopa that you can break into 80 pieces and more accurately take the amount that you need. It's, I just checked actually this morning, the price of it's now over $100 for a convenience. So I just tell people, just break it. Break it in half, try to break it into quarters, see what you do. The idea here being, sometimes in advanced disease, even small changes in the dose of medicine have a big effect. when we talk about making medication last longer, so there's carbidopa, levodopa, and it's shown on this graph. I always like this graph. The green is regular carbidopa, levodopa. Yeah, hopefully it's green up there too. It peaks up really fast and wears off really quickly. So then they made the controlled release, the CR, around 1991. That one doesn't peak as high, lasts longer. Nice. You have to remember that it's not as strong as the original stuff. Then they made this stuff called Stalevo. Stalevo lasted even a little bit longer. It had another medicine in it that reduces how quickly levodopa is broken down. That lasts longer. And then came this Impax 066. Most people know this as Rytari. You take a dose of that, it kicks in fairly fast, not as fast as the original stuff, and it lasts much longer. So there's if you don't have to take the medicine 6 times a day or 8 times a day, maybe only take it 4 times a day. That'd be great. There's a one-up, so Impax came up with their subsequent medication, which is 203, commonly known as Crexon. So that's been out for about a little over a year. Some people aren't, the Crexon people were here to tell you how good their medicine is. It's probably a little bit better than the original Rytari, a little bit smoother, probably lasts a little bit longer. And if you're able to get it covered by insurance, you could potentially maybe only take it twice a day. But it's hard to get insurance companies to cover it when you only need 2 doses a day. So again, we make this progress. This has been something that's come out again within just a little over a year ago. And something that's getting more and more widely used. The ideal thing to do would be to give levodopa continuously. And this therapy has been around for a while. This is called Duopa. It is where the medicine carbidopa, levodopa goes right into your intestines through a surgically implanted tube. So, is it possible to click that video? Oh, I guess I'm not going to have videos. Oh, wait, there we go. So this is one of the patients who was in the early studies. That's the size of the... Oh, all right, well, okay. Well, anyway, this... So this was the early sort of continuous therapy that was available in the United States and elsewhere around the world. Because it was surgically implanted, there were some complications with the tubing. I had some patients who used it, but we're always waiting for something a little bit better. So, oh well, all right, well, it was just, I just want to give people a sense of what it was like. This is sort of the next generation that we're seeing in carbidopa, levodopa therapy. Again, continuous therapy is what we're after. We don't want the medicine to wear off, and we want to hit the dose just right so that we don't get side effects. So the ideal thing is just to get that sweet spot, that, Goldilocks, right? Not too hot, not too cold. So this is one of the newest therapies. It's been in Europe for a few years now. It's been here in the U.S. available for actually under a year, and you can get it. I have several patients on this. It provides a subcutaneous, which means under the skin, form of therapy. So the levodopa, carbidopa, levodopa, instead of taking it by mouth or getting it pumped in through a tube, is going in through a tiny little tube with a little cannula, a little tiny straw. It's really tiny, that infuses the medicine under your skin. And then it's absorbed continuously and slowly. You can change how fast the medication goes in. You can give yourself extra doses. And there's no surgery involved. You, as a patient or a caregiver, you have a little device that puts the cannula in. It takes a second. It's, I'm told, painless. That's what they tell me. And then you get hooked up, and you leave it on. People use it 24 hours a day. You can have it during sleep. For people who have trouble sleeping overnight or have trouble getting up and going to the bathroom in the middle of the night. So this has really been something, a bit of a revolution. I think this idea of continuous dopamine stimulation has been something that science and pharma and physicians have been after for a long time. And this is sort of our best look at this in the United States anyway, in a long time. So I'm really excited about this therapy, and I'm hoping it turns out to be as powerful as I hope. There are other ways outside of levodopa, carbidopa, to make these doses last longer, and I just listed a bunch of different medicines. I won't go through all of them. Most of them have been around for a while. I've talked about them, in this at this symposium a couple years ago. So different medicines. So some are MAO inhibitors. These reduce the breakdown of levodopa, so it lasts longer. COMT inhibitors, it's the same class of, these are all similar medicines that are shown up here. Opicapone is the newest one. It reduces the breakdown of levodopa, just the way the MAO inhibitors do, so the doses last longer. And then there's dopamine agonists, and I'm going to talk a bit more about that. These are medicines that don't really involve carbidopa levodopa. They pretend in the body that they're levodopa and activate those dopamine receptors and take the place and the substitute. And there's a variety of different forms of oral ones in that as well. There's another medicine called istradefylline that can also, seems to make levodopa or the effect of it last longer, and something can treat Parkinson's on its own. So these are all different things. I just wanted to mention them. Some of you may be on them, have heard of them. But these, again, all this notion that levodopa, although it's the best drug, it's not perfect. And we look for ways to make it last longer, and then I'll talk a second about how to treat some of the side effects. One of the other things that's new this year is the apomorphine pump. Again, we had a person here talking a bit about that out front. So this has been around for 30 years in Europe, and I know over the years I've always wondered why it's taken so long to get here, but it's finally here in the US. Apomorphine is a form of a dopamine agonist, so it's not levodopa. Now it's now available here. I don't have anyone on it yet, but that's sort of my next goal, is to find tissues to put on this new therapy. It is being used in this region. Some of you may be using it right now. So again, it's something that continuously stimulates the dopamine receptors. And the pump is probably a little bit more convenient. There's a lot more experience with this medication because of all the time it's been in Europe. Most of the time with the carbidopa levodopa that I talked about before, those folks who have that pump don't really need much in the way of additional medicines. These folks often still need to take some pills. But it may be a little bit more possible for people on this pump with pills to be a little bit more fine-tuned in how well their symptoms are treated. So moving a little bit forward into some of the experimental, so just while we're talking about dopamine agonists, this is another one that's probably eventually going to be released. Most of the data are supportive of it. It hasn't been filed for the FDA for approval the last time I checked, but maybe another medicine coming on board. So just, you know, people are still working on this. There's also things that we use for rescue. So there's an injection of apomorphine. That's the same thing that's pumped continuously. I talked about a moment ago. If you have off time and you need quick rescue, there's an injection for that. It's been around for a long time. There's also an inhaled levodopa. I have several patients on this. When they feel like their medicine isn't working, they can take a little inhaler hit of levodopa and then hopefully rescue how well they feel. So when we talk about what some of the problems are with levodopa, you know, again, the side effects, we can't slow progression of the disease in any particular way that we know of so far, except maybe with exercise. So the disease progresses and it becomes a little bit harder and more tricky to treat. That's why there's so many different medicines. There's 29 Parkinson's medicines out there. So we know that there's these peaks and valleys, the wearing off of the symptoms that make us want to get the levodopa to last longer. We know there's dyskinesias, involuntary movements. I call them the Michael J. Fox movements, right? So it can be listing to one side, or can swing a little bit, or a little bit more like dancing type movements. And that's something that is a side effect of levodopa. We also know that things progress. There's thinking and memory problems as well that we need to address. So the one thing that we are able to look at is how to maybe dampen down some of these excessive movements. Amantadine and a similar medicine, a long-acting form of recovery, have been out there treating dyskinesias now for a while, for a long time. The amantadine story is interesting. It actually was it's used to prevent the Asian flu, and then some very notable doctors at the time realized that people who were taking this to prevent the flu, or treat the flu, who had Parkinson's, their Parkinson's actually looked better. And so then it was kind of an accident that they discovered that this medicine can actually treat Parkinson's. So I've included this slide for a couple of years, and the main reason was to talk about this next slide, future treatments in trying to dampen down dyskinesias. And much to my dismay, when I kind of looked through it, there's only one of these 4 medicines that still kind of has some hope of treating these excessive movements. And so again, this is something that's not quite available yet, but hopefully if it does pan out, we'll have another medicine to dampen down these excessive movements. One of the other big things that happened this year is that the FDA reduced some of the requirements in using a medicine that we use to treat hallucinations called clozaril. So people may know that Parkinson's plus levodopa can lead people to see things that aren't there. And the medicines that we use for that can have some side effects. One of the most potent, most valuable ones out there, called clozaril, used to be monitored by a program from the FDA that required lots of rules and restrictions and blood tests, and some of that's been relaxed. So this idea that we can use clozaril now more freely is wonderful, and I've taken advantage of that already. Hallucinations can be very disruptive and disturbing, and so it's great to figure out a way to treat that. Some of the other big things to talk about, the surgical therapy. So the 2 big surgeries that we use to treat Parkinson's, one is deep brain stimulation surgery, the other one is called focused ultrasound. I'm going to talk about DBS, or deep brain stimulation, first. It's been around for a while. One of my favorite things to do as a movement disorder neurologist is turn on these stimulators and program away people's Parkinson's symptoms. It's quite powerful, quite enjoyable to do. It's one of my favorite things. There's been probably close to 500,000 people treated with DBS throughout the world at this point. There are different targets depending on the major symptoms of your Parkinson's, and we can adjust different things. So as you can see, hopefully by the picture, it's exactly what it says. We stimulate areas that are deep in the brain. Put little holes in your skull, they slip this tiny little like fishing line thick wire in there and stimulate these deep brain areas to treat the Parkinson's symptoms. So, been around for a long time. We're very good at it. This region between DC and Virginia and Baltimore, lots of surgeons. We do a lot of DBS here. Still probably underutilized. There's probably still more people out there who could benefit from it. So if we could maybe get this video to run, that would be wonderful. Hey, yeah, it's kind of small, but oh well. So this is some of you who are following at the University of Maryland may have Dr. Rich as a patient. This is one of his patients. You'll see a picture of him in this video. So this is a gentleman who was off medicine and was being filmed. And you can see his Parkinson's is pretty disabling. So he's trying to move, he's got the tremor. He'll try to stomp his feet, move his hands. Some of you may recognize this is part of the Unified Parkinson's Disease Rating Scale examination. So a lot of the examination features are the same as you may have been doing with your neurologist. And what this shows is the gentleman, this is an off exam, so no medicines are being given. And this is kind of what he looks like before deep brain stimulation surgery. And towards the latter part of this video, you'll see him when he's on, when the medicine still doesn't have medicine, but the device is turned on. So his tremor is better, his movements are better, and probably most remarkably is his ability to get out of the chair and walk. So, let's see, what else can I talk about while it runs? So, recently, a study came out that showed the durability of the newest version of DBS. We know that after 5 years, that there's still a significant improvement in symptoms. Other studies have shown that even after 10 to 11, in an unpublished form, 15 years out, that the deep brain stimulation surgery is still useful, still effective. It doesn't slow the progression of the disease. So there's Dr. Rich, for those of you who may have him. It was a couple of years ago. One of the things that we do as part of the UPDRS, Unified Parkinson's Disease Rating Scale, is we try to knock you over, right? So some of you may have experienced that. Stand behind you, give you a pull backwards to check your balance. Because if the harder it is to recover from a pull, the more afraid we are of falls. So here's, I think, see how to do with the timing. Dr. Rich is going to try to pull him backwards. So again, not being on medicine, not having a deep brain stimulator on, he is going to fall backwards, shuffle backwards. And you can see if you're kind of walking along and you meet an uneven surface, throws you off balance, it can be hard to recover. So here's this gentleman after the deep brain stimulator, still off medicine. So tremors better, movements like that, much better. Still probably a little bit of tremor, and you'll see that later. But you can imagine if you see someone, and me, as myself as a physician, you see someone coming in who looked like the first video when they walked in, and then after we turn on their deep brain stimulator and program them, they look like this. It's the best thing I do. And you see, he pops right out of the chair, and he's able to walk. So that is sort of the miracle that is deep brain stimulation. So again, this has been going on for a long time. There's a lot of patients who have had this done, multiple surgical centers in this area. So if you're a candidate, oh, there's Frank. That's Frank Skidmore. He was a fellow at the University of Maryland and worked with me for a while too. But anyway, so yeah, it's nice. Anyway, so why do I bring up this now? Because it's kind of old news. Well, again, the study one study just came out that showed how effective it is, and that those effects are long term. We kind of knew that. We also know that there's new devices, there's new technology. One of the most interesting things has been, again, this has been for a few years now, we could steer the current, and that kind of shows, yeah, that's the right thing. So where that yellow burst is, that's where the current is inside the brain. That STN is the target that we're shooting. We want the stimulation to be in there and nowhere else. And what this new technology allows us to do, like that new, it's getting better all the time though, is to steer that current into its target and eliminate side effects. So that new technology is very powerful. But the thing that's really new in the past year is what's called ADDS, or adaptive DBS, or closed loop. So this is something very exciting. So in the past year or so, the way we program has been influenced by a couple of things. One is, one of the companies out there who does this uses imaging to help those of us, like me, program. I'm not a surgeon, I'm a neurologist. I sit there with a computer and I try to figure out where the stimulation needs to go. So we can link that with imaging so we can see where the lead is and what the best direction and the best place to stimulate would be. So that's one way, and it works. It works really well. So I had a patient, I had some trouble getting the stimulation parameters just right. It took me about 3 months to figure out this is the best I can do. And I had the software people come in and do the imaging, and then we got kind of the same setup. So I felt really good. It's like I figured out the best settings, but the computer did it in like 30 seconds. It took me like 3 months. So these things, so in a sense, we can get people's settings much quicker if we have that technology. The other technology that's out there is using sensing. This is one of the other companies' approach. We got leads, we got wires in a person's brain. We can not only stimulate, but we can listen, in a sense, with those wires. We can find out where there's abnormal signals in the brain, and when we see that, the device can fire to interrupt those abnormal signals. And so, then a little bit of that as well. We use sensing DBS, or deep brain stimulation leads, and again, we have a company representative here today hoping to perhaps talk to you about that. So we use that to help us program too. But the thing that's very exciting, the reason why I definitely wanted to include this, is a paper that just came out on September 22nd, is from a group, I think it's California. I think it's UCSF. Yeah, Northeast. So anyway, so doesn't matter. California. So they were able to do a study where the whole process, in a sense, didn't need a physician. So the device listened to the abnormal brain waves and then fired. And the whole thing was kind of done closed loop. So when I've done it, I see what the device is sensing, and then I make a determination how to stimulate. This is doing it in real time. So one of the things it did is save battery. So there is a battery. Most of them are rechargeable, so it doesn't matter so much, but the device only works when it's needed. There are probably fewer side effects, and the general sense of this paper was that people who were on traditional devices, they did pretty well. They seemed to do better on this device. At least the trend was that way. So again, what's new? In the past year, we're using this sensing DBS, and the idea that a closed loop will exist. It does exist, and it'll probably become more common. Just one other thing I'm going to touch on here is the MRI-guided focused ultrasound. I bring that because that was something that was pioneered by Dr. Fishman and the group here at the University of Maryland, along with the University of Virginia. So we can now use this technique to use sound waves to find out where tremor and Parkinson's disease, where the centers are in the brain, to use sound waves to make a lesion there to try to treat that. It's more commonly used in other tremor diseases, but it can be used in Parkinson's. And just real quick, in my last 40 seconds, I'm going to talk a bit about clinical trials. So, everyone who has Parkinson's can participate in a particular trial without any involvement of anybody else, really. And that's through something called TD generation. I encourage people to sign up for this. It does genetic testing on you to find out if you have any of the genes that can contribute to risk of Parkinson's. At this point, we don't treat people any differently based on their genetics, but there are trials out there, and the University of Maryland, we have 2 of them going on for genetic forms of Parkinson's using specific therapies to see if we can slow progression. So at some point, hopefully in the near future, we're going to want to know what genes put people at risk who develop Parkinson's. Right now, there's over 20,000 people enrolled in TD gene. This is something, again, you go online, you register. At some point, you send in some of your saliva. They send you back a report, no doctors, no insurance involved. So right now, there's only 390 people in the state of Maryland signed up for it. It's embarrassing. So we have some of the best Parkinson's doctors in the state. We should be doing better. So just something, a little plug out there. If you're interested in genetics, this is one that you can be involved in research. A couple of things that people sort of bring up to me in my clinic. So this medicine shown here is shown to be protective in a study that was done in France. More data is needed. This is the same class of medicine that's like Ozempic and Wegovy and these GLP-1 drugs that are kind of the talk of the town now. We did a study of a long-acting form of this medicine that unfortunately failed to slow progression. So I'm not 100% enthusiastic about this because my personal experience has been it didn't work, but we do lots of trials with different compounds to find the one that does. So this particular medication may be in additional trials or similar medicines to see if it slows progression. Prasinezumab is another study we were involved with this at the University of Maryland as well. This is a medicine that clears alpha-synuclein out of the body. Overall, it failed, but if you look at the data in particular ways, you can kind of figure where it may have worked. So some people are definitely talking about ways to redo this study in a way that may be positive. And the way we do studies now, and one of our most recently or soon to begin studies, is using endpoints the FDA has allowed us to use to show that something's useful. If we use those endpoints in this study, this drug may be available now because there was some signal of protection. I just didn't, I just want to sum up with this final one. So I went on clinicaltrials.gov, so if you're interested in research, that's one way to find out what trials. There's over 600 Parkinson's, 600 trials of devices or medications or therapies in Parkinson's worldwide that are currently enrolling. So a ton of research is going on. In the state of Maryland, I found 8. In DC, there were 4. And in Virginia, there were 8. So there's a lot of stuff going on that's even local. There's stem cell trials. University of Maryland, we have neuroprotective trials. Gene therapy trials are going on in this area. A whole bunch of new drugs, new therapies. There's a doctor over at Johns Hopkins who's using music therapy and metronome therapy for Parkinson's. All kinds of strange stuff, thinking out of the box. fecal transplants. I often talk about that one, but I won't talk about it now, that's because they. And yeah, so that's kind of it. So just to kind of summarize sort of what's new. So what is new is this sort of pendulum swinging towards some environmental factors. That doesn't necessarily mean there's a lot of new findings. When I first got involved in Parkinson's research, we were all looking for environmental factors. Then later, it was all about genetics. Now it's going a little bit more back to environmental factors. Bottom line is, you'll see these things on, newscasts and big covered magazines. We know age, genetics, exposures, and probably other things are all what leads us to Parkinson's. And why these things are important is in the future, maybe we can avoid things that trigger Parkinson's. Maybe we can find therapies that treat particular types of genetic forms of Parkinson's. Okay. How we diagnose it, we have skin biopsies, we have DAT scans, but it's really just usually a movement disorder doctor making those diagnoses. Therapy, new availability or better availability for hallucination medicines. We have 2 new pumps that are available, just like insulin pumps kind of revolutionized how we treat diabetes. These pumps may revolutionize how we treat Parkinson's. We have new deep brain stimulation technology that's going to make it better and more efficient. And then there's always tons of trials. And if you, 75% of the people who did that PD generation, the over 20,000 people, never did research before. It's the first thing they did. So make Maryland proud. Anyway,